Do you have a bell? Ding, 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 ding. All right, is everybody ready? We'll get started. We're still waiting on a few members, but we can start and we'll get everything going. The attendance sheet is coming around. If everybody could please sign in. Thank you for coming this morning. The minutes went out attached to your agenda for this morning. Hopefully people read them. And if I have any motions for corrections, additions, deletions, please make them now, otherwise we'll approve them.
I checked everything out.
Oh, okay. Trev, did you get it?
Yeah, she got it.
Okay. Any problems with the minutes? Okay, thank you, Dennis. We don't, well, we can. She did. Oh, do you want to have?
I don't do it.
Yeah.
Oh, no,
no.
I can't do it.
No, I mean, you're just going by this.
That's entirely up to you.
Yeah.
You want it in the minutes, otherwise it's, the appearance sheet is in the
She
front,
puts
which
all the
is-
people in.
It's all up to you guys.
So Dennis is the first motion. A second?
Second.
Thank you. So I might be amiss, however, I'm Pam Murphy. I don't know you, Jeffrey. You're new from Nyack?
I am.
Okay, introduce yourself a little bit.
I'm Dr. Jeffrey Raybridge. I took over as the director at Nyack ER a month ago. Long history of EMS in the region. I started with Rampo Valley Ambulance Corps in Rockland County and then worked many years with Rockland Paramedic Services. Currently,
So you had to work with Murphy?
yes, I had.
I'm sorry. That's my brother. That's my brother from another mother.
Yeah. Currently, medical director of the Tactical Medical Support Unit for Rockland Paramedics, subspecialty boarded in EMS, and
You gotta
also.
slow down for me, Doctor.
I-
You were the medical support unit of something?
TMSU, medical director for Rockland Paramedics, subspecialty boarded in EMS, and also the vice chair of the New York City Remac.
Perfect. Thank you for coming. Okay, so this morning we have some old business to go over, and then we have some upgrades, and we'll make our way through. It's a pretty hefty agenda, but you know me, I can fly. Okay, so under old business, the 2017 Collaborative Protocol Rollout Update. Mikey.
Okay, so we are still working on the policy procedures manual. That's all of the pieces that came out of the collaborative from its last edition. We're breaking them and putting them into individual policies. There'll be one on medication and medical control, transfer of care, aerial medical utilization, emergency incident rehab, specialty care transport, medication facilitated intubation, which is now again called RSI, and clinician on scene. One of the things that we did want to bring before the body today was use of OG tubes. It is in the collaborative protocol, and we'd like the region to adopt that.
So what the point there is, and they've been using it in other regions, is to place an OG tube just to, of course, decompress the tummy and help facilitate proper oxygenation and good CPR and compressions, and take some of that resistance away. So they've been using it in other regions we just never had, and so it's a new addition of to our protocol. So we wanted to bring it forth to you guys here this morning and open it for discussion and then vote. Any discussions about OG tubes? Don't everybody talk at once.
Pretty straightforward.
Okay, so then a motion on the floor. You want to make a motion? I'll make a motion on the floor. Motion on the floor to accept the protocol to include administration and application of OG tubes for patients that require it during the resuscitative phase. All those in favor? So we have unanimous. Thank you, everybody. Go ahead, Mike.
There was discussion with regards to the BLS protocols and agencies and providers following the collaboratives. At the last CMAC-SEMSCO meeting, it was announced that protocols are both driven by the state as well as regions. Therefore, the regions are allowed to have BLS providers follow the collaborative protocols. We discussed this at the last protocol meeting, and the state is actively working on the development of New York State BLS protocols. They look very similar to that of the collaboratives. And Dr. Daly is spearheading that group. And so it's the recommendation of the protocol committee to not roll out any education from the region at this point for BLS providers and wait and see what the state does. They're hoping to bring the first copy for approval at the September meeting. So rather than try to roll this out over the next couple of months and confuse providers with a new one potentially coming out by the end of the year, we've just decided that we bring it to you to just hold off on any BLS education.
Yeah, and what it'll be is a much more smoother rollout, and we'll all do it at the same time and all be on the same page of using the same resources again, just like we're doing with ALS. So it only makes sense for us to wait on that, and then we'll roll it all forward when it's ready.
I have a quick question on that. The BLS protocols, the original collaborative BLS protocols were rolled out, and some of the agencies are using them. So will they be allowed to use them as well as the New York State?
Yeah, I mean, Lee made it very clear that providers could follow either the collaboratives or the New York State and be within their scope of practice. It's just that educational component, Bill, that we don't want to confuse everybody about. So, but a provider could use either protocol and be within their scope. There are also several things that are in the new collaborative that the region needs to discuss with regards to reporting, and it's the recommendation of the protocol committee to just do this, so that there would be a monthly report that would be provided by the agencies that would report such things, and Jeff, let me know if I miss any: needle decompression, chemical restraint, and excited delirium. A requirement that medical control be contacted for adult and pediatric hypoglycemic patients wishing to refuse transport, OG use, pediatric allergic reaction, contact medical control for an RMA, and also approve the use of nasal tracheal intubation. So those are pieces that are all regional options in the collaboratives that we want to move forward with all of those.
Okay. Now, it's really more so part of the educational process, and people got to see all those things, so it's really more a notification because it was all in there. It does change what some people do. We have one agency that has applied for and has received, I believe, their ketamine, and that's just the one. So I think that otherwise, we can just move forward because we don't have to act on that. That's more just a, passing along the information. Okay.
Right, that's all I have.
Okay, great. Narcan update, Bill. Jeffrey. I'm going to pass that baton all the way around.
We finally did get another shipment of Narcan about a month ago. By the day after, we had about half of it left. We have gone through, we've distributed approximately 900 doses so far this year, which has already exceeded what we did last year total. We still have some agencies that have yet to apply. We're also waiting on some agencies to submit the training plans. The last set of paperwork that we received was from Curious Joel last week. Their paperwork is complete, the training plan is complete. We should probably bring that up for approval this morning, and we can actually give them their Narcan before they leave today.
Okay. And I'm sorry, somebody just sent me a text. Who is it for?
Curious Joel.
Curious, KJ. Okay. We'll put that, do you want to do it right now? We can do it right now. So you have a completed application, everything's there.
Everything's there.
Okay, so basically, with these processes, it's really us just saying we want to facilitate people getting Narcan and putting it out there. The process is the agency puts together the application, gets all their ducks in a row, gets their educational process, makes sure all their people on board. sends all the information to the office. We sign off on it, make sure it's all there, and that the feedback will be there. We get the cases, we get the data back, and then we're really just giving it a blessing. So this morning, why don't we'll make a motion for approval of KJ to participate in the Narcan program with a completed application and completed processes that are all substantiated. And I put a motion out there to approve them for Narcan. All those in favor? Great. So we're all the way, again, what's the word? Yeah. Thank you. And then I have, I can announce this one too then at the same time. We have two agencies that are service upgrades. You'll see them on the agenda. Cragsmore Fire Department has a BLS First Responder Program, and Putnam Lake Fire Department has a BLS Responder Program. And they too put through all the paperwork, was all approved, and actually we have the letter back from the Department of Health that they even have their agency code numbers already. So both Cragsmore and Putnam Lake are approved. They're registered into the agency code and the CME process, and really, again, a notification for the region, but something that this is great. Everybody moving forward, doing upgrades. It's all good stuff.
I think we need just to vote on that also.
Oh, I do. Okay, guys, I have to vote again. So, to vote on Cragsmore Fire Department for their BLS First Responder upgrade, all those in favor? Anybody know where Cragsmore is? It's like the most beautiful place. Actually, it's Sullivan County, really, right? It borders.
No.
Is it still? It's still orange?
Ulster County, but it almost got wiped out by the large fire up there.
Yeah.
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 You know, 'cause it's right
It's
up near
Ulster?
Sam's Point.
Oh, I guess you cross over. I was thinking. Okay, it is.
You go up
it's a-
52. It's your general approach is 52. If you're
It is
going towards
beautiful.
Ellenville.
You can hike up there, and just like they say, Cragsmore Crags are, the elevated mountains in Scotland is where they all came from. And it's filled with Scottish people. I know so many Scottish people that live up there. It's a beautiful area. Okay, I digress. Next one is Putnam Lake Fire Department, BLS First Responder. And they also were approved, again, asking the committee here, all those in favor? Unanimous again. Okay, thank you, guys. So on the agenda, I skipped over it, but we'll jump back. Hospital diversion. I don't have anything more on this. Yeah, I think it's, anybody has anything more to add? We were watching it and making sure that diversion didn't become an issue. We've, utilized the resources of Westchester, where you can go on to the site and look at every single time someone asks for diversion, goes on diversion, and all the tallies. But I haven't.
I think we were gonna there was some plan to send a letter out to all the CEOs and all the players involved.
We did that.
We did that?
Didn't we do that, Karen? We did that this committee favors no diversion, right? Okay.
I don't think
I don't believe that went.
It didn't?
And there was
Because then the plan
discussion-
was to re-vote
there was
on it and
discussion
eliminate
that we were
diversion.
That we were gonna write a policy too, Jeff, was there not? There's a policy that was gonna be written, the manual from Westchester was gonna be distributed, and the distribution was gonna occur, and that has not happened.
Okay.
Got stuck on the letter.
And wasn't that supposed to be the OEMs, the dispatch centers?
Yeah.
They were gonna be
Yeah.
included in that.
But I thought you didn't want the letter to go out, so that's why we stopped it, I think. Because you said you wanted something else done before the letter went out. You wanted to make sure, do you remember? You wanted to make sure,
I wanted to vote to get rid of it, and then Arshad said, wait, we gotta bring everybody
oh,
involved.
maybe it was Arshad then. Somebody stopped it that day. Remember, we had to
Yeah.
table it. Maybe it was a
And then I
shot.
think we said we were gonna send a letter, a collaborative letter, saying, guess what, this is what we feel is
Yeah.
best for our region, and this is what we're doing, and then, once that kind of circulated, I thought we were then gonna revisit the issue to sort of vote on potentially getting rid of diversion except for specialty.
Yeah, and we said, the emergency kind of processes, just like you guys had done at Westchester.
Yeah,
That-
we don't have, general diversion anymore, except for that.
Yeah, disaster or emergency inside the facility that,
Right.
Yeah.
So, since he's not here,
Why don't we just have a vote?
let's have a vote. Because I'm pretty sure, I wasn't sure how it stopped, but you're right. We had to put it on hold because he wanted to make sure.
But quite frankly, I mean, we sort of stopped it, because we did, as I recall, we were talking about it for about 45 minutes. But I don't know, I mean, it's nice that we send a collaborative letter to the CEOs, but I think they're aware of whether their ERs are holding patients in the, does it matter?
They aren't.
They aren't?
I mean, look, this is still a chronic problem for emergency medicine, that they are not moving patients up fast enough from the thing. So I think we should definitely send it out.
Yeah, I think it
to
just
them.
gives our
And we probably have
place.
to repeat it every year.
Yeah. I mean, I feel like
Because until these folks finally get it.
they're complicit in it, because,
Yeah.
it's OR cases.
So I really think we need to push it.
Yeah, and I would reference the Dear CEO letter that was sent by the commissioner to CEOs regarding ED crowding in December of 2016, where they specifically talk about diversion there and
Yeah.
activate your disaster plan in regards to diversion, so.
Yeah, and what we were thinking about doing, you weren't here, Jeffrey, for the conversation, but what we were discussing was, we as a body could say, we don't believe in diversion. You can do it on a emergency basis, a disaster, facility
Cat
issue, something that's out of your control. A hurricane comes and takes you out, So that's what we were looking at. Westchester had, a pretty straightforward, you read us part of the letter too.
Yeah.
Yeah.
And that was a couple of years ago, and it's helped.
Yeah, so we as a body wanted to do it, but we did have one dissension that was like, let's wait and do, so let's vote again. So all those in favor of, I would like to draft a letter to go to all the CEOs of the hospitals, and as Rich aptly pointed out, we wanted to go to each one of the 911 dispatch centers, and what we would say is our policy, our stance, is that we just don't believe that diversion is good for our community, for our patients. Sorry?
It's bad public policy.
Bad public policy, I'll quote you. And that we send this out, with all of us on it. We can list all of our names on there, and as a body, as a group, as a medical advisory committee to the area, this is our stance. All those in favor? Great, unanimous again. Thank you, everybody.
Can we talk about enforcement now?
Yes. Absolutely.
Are you familiar with the letter that Jeff was talking about?
That's the problem.
From the hospitals?
Yes.
Okay.
But, I mean, if you have somebody who's chronically, we say it's the problem, but we haven't really had to address it. Really, when we looked at our listing for last year, there was one hospital that was problematic, and they fixed themselves.
Yeah.
Pretty much once it was.
Yeah,
really an
it was,
issue.
it became light of the administration that they actually didn't really realize how many times it was happening, and what was happening was people at the mid-management level were calling for it, and the real administrative people on call, the one person who was there, like, your on-call person in the middle of the night who has no clinical stuff was being called, and it was going on. So once that quantity was brought to them and showed, and the processes, so, yeah, and I'll take responsibility for that one. But it's really, since January 15th, there's been none.
You take credit for it, too.
No,
at the same time.
no, it's
And I fixed it.
it's everybody's work. It's everybody's work. But it's a thing where, it really was a thing, he didn't realize the amount.
Well, after we implemented it in Westchester, we, basically, if someone starts asking for diversion, John and I will get called by Michael Volk from EMS, and Westchester County, and he sort of let us know. And so then we did a little investigation, and, you know, so it was that kind of same thing. There was just like, okay, no one really knows what the rule is, and then some administrator says, hey, you know what, we're getting overflowed, let's go on diversion. And all of a sudden, they started kicking it over there. So, anyway, that just came to an end. So it's the same thing. Sometimes it's new folks coming in, it's, you know, an administrator's unfamiliar. So it's helpful if the policy is in place, and then, you know, there's a feedback mechanism so that if violations start happening, then you can get on top of it before it really goes anywhere.
Yeah, and I think the website is really useful,
Yeah.
and requiring any kind of diversion notice to be through the website is good because you can track it at the outset, and I think that's something, regardless of, you know, we can make a very hard policy on it. I mean, you know, it's hard to say. I mean, there have been cases in Westchester where someone went on diversion and people were like, oh, you know, it wasn't the end of the day, end of the world, you know. The goal isn't to you know, make everyone's life harder. But it reduced it dramatically. But the thing that's really helpful is to have the tracking ability. And you can definitely make a policy that says, if you want to go on diversion, you have to go to the website and say you're going on diversion.
Yeah. I think that should be added into that, because that tracking, you know, thing is good, and it's also good for sort of disaster and MCI response too, because it puts all the hospitals in at least one place where people know to go and see what their status is and availability and their capabilities. There's their capabilities in there too. So, you know, that's the kind of stuff we need to centrally track.
Okay, Karen, you ready? We're doing this after the meeting.
You're doing what?
The letter. Okay?
Okay, you and Jeff can work on that.
It's important also that the 911 centers be educated with regards to that system, because certainly the ones in the upper portion don't use that today. So as that gets built into the letter, the 911 centers need to know how to use that and need the access to use that.
We could add it onto the bottom of the letter.
Yeah.
You know, and just explain that it is a centralized tracking system.
Yeah, it's run out of 60 control.
Yeah.
And everybody already has
Fairly
an account.
robust.
He just has to act, you know, if they don't remember their password, he can send it out. They're all set up.
And there was a manual, maybe that manual could go out with the letter. Right, Bill, you have a manual.
Yeah, there's a manual for it.
Yeah, so that should go out with the letter, so that they all have a new copy of that.
And I actually for the ERs, I wrote a one-page, because the manual is a little bit annoying to store in the ER, so I wrote a one-page document on it that they can kind of put with all the other one-page documents in the ER and the board.
Even on a random wall.
Exactly. Everyone has a
Just keep
random
side
wall.
pages.
You're not ER if you don't. So yeah, so if I can give you a copy.
Yeah, do you want to just send it to the office? Because I think that's better sending out the one pager than the whole manual.
Yeah.
We can
Well,
attach
I
the
think
one
you need
pager.
both, because there's some functionality that's in the manual that I just couldn't put in the one pager. But for general, like how to use it, how to, like that kind of stuff, it's enough. You don't need
It's pretty easy.
15 to 20 pages.
You almost can do it if you have a login and never learned. It's not that.
Well, we say that, but then someone calls
Yeah.
us at 3 in the morning saying, I don't understand.
All right, great. Thanks, guys. All right. We're down to evaluation subcommittee report. I don't think we've had anything, right? Dr. Rashad's not here, but I don't think we've had
No.
issues.
No badness.
No badness. Dr. Berkowitz, helicopter committee report.
There's nothing really new on the helicopter front unless anyone has any issues with recent. There's no report.
This is going quite fast. RTAC.
I'll speak to that. So,
Okay.
there are a couple of things. So they're doing their PI project for the RTAC. The last one that they did was regarding transfer times. The one they're focusing on right now is regarding oxygen. Both on, I think the two main groups of patients we're looking at are interfacility transfers where there's a TBI and a significant TBI, but they're not intubated. So that's one cohort they're looking at. The other one are scene calls where they have a significant trauma. And they're still working on all the parameters. They did share some data regarding patients who arrived without oxygen. And there's clearly some pretty significant, patients who are hypotensive and in shock, who may not have been hypoxic, but certainly would have warranted to have oxygen on. And I think that we should be encouraging that. And I spoke to them about the methodology, because I wanted to make sure that they weren't missing patients who maybe had the oxygen pulled coming from the ambulance into the hospital. And they said they were reading the PCR. A lot of times they were asking, someone was asking the crew when they arrived if the patient had oxygen en route. So I think it was a pretty reasonable assessment that they put together, and I think that generally they're going to go forward with it. So just put it out there that they'll be looking at that as a QI project. Because this is so EMS heavy at the RTAC project. I'm talking to them to get us, really anyone in the EMS community, especially the county coordinators and those kind of folks, invited to all the RTAC meetings, so they can participate. So it's a bigger table. So you should expect to see more people on that. It is kind of generally open anyhow.
Yeah, you just can't vote. Anybody can go, you just wouldn't vote.
Just a little bit more on this. So this study came out, this is out of this EPIC trial, I guess.
Yeah, the one in Arizona?
Yeah, this is the one in Arizona. So they're really trying to look at this whole oxygenation thing. Now, from the data that they're reporting is that in someone who's got a significant head trauma, one episode of below 90% oxygenation has something like 6 times worse outcome in terms of their thing coming out of traumatic brain injury. So, pretty important thing. So, the guidelines that they set down, and I'll just read these, are the pre-hospital identification of moderate to severe TBI. And I think it's this first category where we're missing the boat a little bit. Any injured patient with a loss of consciousness, especially those with the GCS less than 15, or confusion, or multi-system trauma requiring intubation, yeah, no kidding, and post-traumatic seizures, whether they are continuing or not. So those last two, pretty obvious. We're going to probably, be tubing them or certainly giving them full oxygen. But it's that any injured patient. See, what they were starting to see was folks that were coming in, vital signs are stable, maybe whatever, they've got a broken arm, something going, some other trauma stuff going on. But then they find out that actually this person got knocked out, okay, and probably has at least some type of concussion or something, and so far the data shows oxygen helps in that kind of situation, and so those people should be oxygenated. And that was, I think, the people who are sort of slipping through the cracks. So that's one of the things that they're really going to monitor. This was called, I think it was called the EPIC study, and they came out with the EPIC TBI, traumatic brain injury algorithm for adults. And so I think they're really doing a pretty hard study on this in Arizona somewhere.
Yeah, because I don't know that we honestly know the answer yet, because if someone's saturating well and they're concussed, I don't think just conclusive data that oxygen benefits.
Yeah, okay,
so,
but at least this is
what
they...
Guys.
I'm sorry.
I'm running, you're like 25.
Because our trend recently has been, right, if they're sad, in most things in general, if they're satting well, we're not, so before we reverse course and start confusing our providers, I think we should be clear on the data.
So I think that the groups that the study is looking at are the more severely. I don't think they're actually looking at a scene call of a patient with a GCS of 15 and LSC. As I don't think that. I mean, that was something in the data that the trauma service presented. That wasn't the groups that they presented. They're presenting people who were coming in hypotensive, with severely injured, maybe with or without a head injury. Regardless of the head injury, those patients should have should have non-breather on them, as well as transfers where the patient was maybe a GCS of 12 and they're known to have been transferred for a head injury, and they were also without oxygen. I think that the general the minor head injury group. which I think we've all agreed, GCS 15 with the LOC would fall into. The data's not on that, and I'm not gonna, we're not, you know, I think that's not part of the focus. And I will, for the sake of interest and thoroughness, I'll make sure I get their criteria that they're gonna have, because I think they're different than what they're doing in Phoenix.
Right.
But there definitely is like a group of patients who, like when they put the data up, you're kind of like, everyone's like, wow, I can't believe that, even plasmoxicon, I'm like,
But I think this is what you just said. We know it's harmful if their stats are low, but we really haven't proven anything
Right.
about, when they're above 93 or 94, is it really beneficial, right? Is it?
yeah, there's nothing beneficial. They have to have an injury that's where they have potential decompensation that you're actually preventing the hypoxia.
Right, because you're not saturating, if they're saturating well, what you're trying to do is prevent the desaturation that may or may not occur, we don't know.
Exactly.
So,
But in the world of trauma, the outcomes are so good. The mortality is so low now in the trauma center, and that it's hard to get. You're really looking at preventing things because
Right.
it's not, it's not the era of these heroic saves where.
which then becomes somewhat theoretical because you're trying to present something that may or may not occur.
Exactly.
So,
Yeah.
But we don't know.
surgeons are sometimes good evidence. So.
But we do know that the evidence of hypoxia, and that, especially when it's confounded with hypotension, really worsen the outcomes. So we do know that. And we do know that a certain percentage of patients do deteriorate en route. And we're just trying to figure out.
How to identify it.
Exactly.
Well, the other addition in this study is certainly in the management of ventilation. They also talk and caution very heavily against hyperventilation, because that's also been shown. So
Right.
that's the other end
And
of
using the end-tidal CO2 to monitor.
Right, exactly.
Keep going.
Sorry.
No,
So-
you guys, I understand that you don't get what I do, and that what you're saying is completely normal to you,
Yeah.
but especially if you're talking at the same time, I can't get what either one of you saying.
We do it on purpose.
I know. After 10 years, Dr. Papish, I know.
And you keep coming back.
I know. So anyway, Dr.
Okay. So anyway, that's the other sort of corollary to that is, so yeah, I don't think but it's just something to be wary about, and so that's certainly one of the focuses of what they're looking at, the trauma.
The other thing is, after the RPAC, they had a training on Stop the Bleed, which is ACS, essentially kind of a first aid type of program for civilians. And a bunch of us got trained as instructors. And I'm going to see they have like a box of gear and stuff. And after one of the Remacs, that's not a Remacs. If you folks want, I can put together a training session or a training instructor session potentially to really widen the scope. So. I'll put that out there, and if you want to set it up, just let me know, and I'll get the.
Do we get a box?
The box.
Yeah, it is a good thing, and basically we can turn everyone into instructors here.
Pretty much,
yeah. Yeah, pretty quickly. That's the way this course is set up. So, and I think it's a very important thing to. It's good for certainly all first responders, but it's something that they're really pushing out into the public, just like you have an AED box posted in a public spot, like an airport. Right next to it, you're going to have a Stop the Bleed box that you're going to rip open, and it'll set off an alarm and signal appropriate, but it's going to have things like clotting stuff, tourniquets, that kind of stuff.
Yeah. So
in it.
We can talk. We'll talk afterwards, but we can, if there's interest, we'll make it happen.
Okay, great, thank you.
When's the next RTAC?
So the next RTAC.
Has not been set.
It's very hard to find that information out. If we want to increase attendance, maybe if you can get the stuff to Bill, you can put it up on the website or push it out, but finding the dates of the RTACs is difficult.
Yeah. Well, in all, like all trauma centers, there's always a change of personnel, but let me see, I'm working to get I'll catch a water net, and I think because we're focusing on EMS, we really need to make it as open as table as we can. So I'll get you, I'll make sure that everyone's involved.
Okay, great, thanks. Quality improvement report, Jeff.
EPCRs remains a big topic. We have ESO coming in today after the Remac meeting. We'll be here about 12:30. And again, tomorrow, Mid-Hudson Regional from 10 to noon. Any agency representatives, anybody that's interested in how the data moves and where it's going and how to get the data flow back from the hospitals eventually, more than welcome to attend. They will be supplying some food refreshments. The other portion that we're looking at is, per New York State, the final move to the Nemesis 3 bridge should be theoretically in place by the end of this month. Although we have heard this rumor before, we're hoping that there is some truth to it this time, and Mike Taylor has assured us that they are ready.
Okay. Thank you. Protocol committee, did you cover everything under collaboratives, or? Oh, do you want to talk about the manual?
I did, no, I've got everything covered.
Okay. Are we going to send that manual out, though, so that everybody can look at it
Yes,
and comment?
Yeah, we're gonna discuss it more on Thursday, the
Okay.
components, and then once we do, we push it then out as a draft.
Okay, so the manual is, remember we mentioned this the last time, the manual is all the stuff we removed from the protocols that doesn't have to do with the whole collaborative committee and really is our local stuff. And so that's what Jeff and the protocol committee are organizing in a separate manual, and we'll get it out to everybody when it's in a usable format. All right, thanks. Okay, under new business, there was a memo and some emails out and about the EpiPen recall. Just wanted to bring it to everybody's attention to please make sure you look at your equipment. The Milan company has set up a website that you can go on for updates on the recall information and how to replace the product. So just go on to milan.com. It has EpiPen recall as the site, but we wanted to make sure everybody out there with them checks their equipment.
Okay, just speak on the since we're on the topic of Epi, the check and inject program has been approved by New York State. The policy is out and the requirements are out under a new policy for this year. So as a region, I think we have to decide if we're going to participate in the check and inject. I think it's left at a regional level. We do have some people that were on the original.
Yeah, there's also more information with that too from the state, is that the state actually has changed the scope of practice of EMTs.
Right.
To include the ability to draw up and administer using syringe, needle, and vial epinephrine only in the cases of anaphylaxis and severe allergic reactions. So there's a training program to go with that. It's all set by the state, and that's being rolled out as a requirement to new EMT original programs and as a component for refresher programs. So that is a thing now. So you may get EMTs to call in to administer epinephrine, and this is all because of the
Check and inject.
It's a function of check and inject as a function of the gouging by the
Milan,
pharmaceutical
yeah,
companies.
it was that company.
Yeah.
But didn't the state change part of check and inject because of the special syringe we used? They changed.
Yeah, it used to be that you had to have you got the kit with a special syringe that was marked with P for pediatric dose and A for, and that's what you would just draw up to. Now, they've changed because they cannot recommend a specific brand, all right? So now you have to be trained to use a 1 milligram syringe with a number 23 needle. You draw it up, and they did change that it could be given IM in the deltoid, not just in the thigh. And there was some discussion about that. The training is mandatory for all CIC, CLIs. You have to go online to sign for it, and as Dave mentioned, it's incorporated now in all the basic training programs.
So just some additional information, if anybody wants to look it up, it's 17-06. It's called syringe epinephrine for basic EMTs. And as Rich says, it's a 1 ml syringe, 23 gauge, 1 inch safety needle. And yeah, it's pretty simple. There's no reporting to the region. There is for BLS agencies need to report to the state with their intent and a revised medical directive form. But other than that, it's not called check and eject. Does not require their equipment, and agencies can begin rolling it out on their own. They've changed the scope of practice.
Yes, only for
For
Yeah.
epinephrine. That's it.
Yeah.
That's correct.
And only in the clinical scenario of anaphylaxis,
Correct.
supposedly.
That is correct.
But, and that's not in here, but if you got a severe asthmatic, you can call in and get medical direction from your GM. So, does that apply? Or do you still have to have the EpiPen?
No, I think it's,
Well, they're replacing the EpiPens with this
That's right.
apparatus, so I would think they'd be using that because they gave them approval for the EpiPen to treat asthma in certain scenarios, so I think it's gonna have to overlap. They're gonna have to clarify that, though.
Well, once it's in the scope of practice that they can use the injectable epi, it would still be within their scope of practice if medical control
To roll it over?
allowed them to use it for the asthma.
Alrighty then. Okay, so, and you talked about BLS protocols, that is all coming down. We will wait for the final product to come down and then we'll discuss it again. I put on the agenda this morning psychiatric patients and dispositions of patients, determination of where these patients go. We had a meeting with the Office of Mental Health and a bunch of other players to talk about the problems with psychiatric patients in this region. It's really an issue since we've lost so many beds, and it's become kind of catastrophic where these patients end up, how these patients end up, and what's the disposition of them. It's even more impressive with the adolescent group. Because no one has beds for these kids anymore. So when it comes to the pediatric adolescent group, it's really become catamount. We're having some patients stay in hospitals for days awaiting a bed and still not getting a bed. So the Office of Mental Health reached out and said that they have submitted plans for institutions who do not have psychiatric services, that the patients get cleared and evaluated in the emergency department. And what they've said, especially like with St. Luke's, is that the mobile mental health unit is supposed to come when they call to evaluate every single patient to decide, do they have a mental health issue that requires an inpatient hospitalization for psychiatric disorders. So it's on the forefront because there's so many issues and these patients are just having such a terrible time. So please, people realize that we still want patients to be going to the institution that's the closest nearby and that they need to be evaluated, and mobile mental health is supposed to be called to help evaluate these patients from a mental health perspective. And they can be called to a scene. We all realize that mobile mental health can be called to a home to evaluate a patient and, decide.
Is it the mobile, like Dutchess County Mobile Crisis, or who's
It's,
mental health?
mobile mental health here is Dutchess County Mental Health Crisis.
The crisis people?
They just name it differently in each county, but it's this.
Same organization?
Yep. And it's supported by the state. And we realize that a lot of people aren't using it because I didn't know, actually, that they were obligated to go do these evaluations. So that's what's been brought forward by the commissioner. So more to come. They're working on it. They're trying to solve some of the issues, especially with adolescents. You have Four Winds, you have, Arms Acres, you have a few places, and it's just very difficult for these patients, and parents and families. So we're trying to get it solved. More to come.
Yeah, can I
Just-
Go ahead.
Can I clarify something? So if mobile mental health is called and they recommend admission to an inpatient psychiatric unit and say we're full, and they call us and we say, you know, we have our capacity we can't accept, or we can't take them right now, you know, where is our obligation, you know, if we have room in the access center, do we say okay? Or if mobile mental health says they need admission, you know, I tell them, you guys have to look for, you know, an inpatient bed somewhere else on your own, like what?
Yeah, well, what happens is you can, what I would do is directly call to the psychiatrist, because the psychiatrist is going to know what they have upstairs. They're gonna know what's in their BHU, their access center, the people they're dealing with now. So as an ED physician, I would ask the psychiatrist, this is what they're calling about, this is what they have. And generally, the mental health coordinator or the ambulatory, the mobile people will contact the psych people directly. They should be. Because then they can discuss it to decide what the patient's needs are and discuss, is it something that needs to be inpatient or not?
Can I just interject here?
Yeah.
First of all, mobile mental health never makes the determination whether they need to be inpatient or not. They just make the determination whether they need to be evaluated by psychiatry.
Correct.
So-
It's a psychiatrist who makes the inpatient call.
Right, right.
Yeah.
As far as I know, the majority of the time, I don't think that they actually speak to a psychiatrist in real time unless there's a question.
Yeah. You know, it's a thing where it's supposed to be a coordination of efforts. I don't think it always happens. And like, I didn't even know they were obligated to do this, you know, in
Well,
places.
So I guess they're obligated if we call them, but you know, there's a lot of cases where it's absolutely clear cut, like somebody tried to kill themselves and they're still trying to kill themselves, and they're on one-to-one, then I don't feel like we need to call them. They're not gonna contribute anything, it's just gonna take up.
Yeah, just medically clear them
But
and.
there's, you know, as you know, I mean, probably 70 or 80% of cases, like if you had some help in the community and you had some promises, you know, you can get.
That's where they're immensely useful.
Yeah.
They're in our ER, like, they have one person dedicated that just sits in our ER because we get a large psych volume.
Mm.
And we find that they're very useful for the very clear cut.
The social workers on
Yeah,
that?
the
Yeah.
mobile crisis. I mean, and they're perfectly reasonable. They see the person that's still trying to kill themselves. They're not gonna try to find a game plan for tomorrow, you know, they
Well,
say admit
I
them.
would just add that, I mean, Connecticut, which we service Connecticut, is, you know, we have something like this, like a mobile unit. Their response times have been so erratic that we've basically switched to a just full, we have 2 social workers now, almost dedicated entirely to our ER, which we found to be much, much more efficient. I mean, these guys directly talk to the psychiatrists, and they're the ones that set up all, you know, ultimately dispositioning them, because we don't have room for adolescents, we only do geriatric psych patients.
Murphy.
I didn't hear of mobile crisis teams being called to ERs to do evaluations. That's somewhat of a new thing. You know, in Rockland, we have the behavioral health team, aka mobile mental health team, and really their design is to keep the person out of the emergency.
Right.
Yeah, they go to the scene.
They go to the scene.
Yeah.
And if they decide that an evaluation is needed, then they'll, you know, they can actually remand them to the ER and they'll speak to the psych people then. So really their design is to deal with stuff either by telephone or doing the scene outreach, with the design of keeping them from going to the emergency room and then referring them to appropriate services within the community.
That's what these goals are
All
overall.
hospitals have a psych social worker in the ERs that deal with the walk-ins and deal with the cases that come in. So I didn't hear of behavioral health being called to ERs.
This is what the state is saying is the process they've set up for places who don't have the social workers or any kind of person there to help evaluate or to help assist. So it's a Band-Aid, let's put it that way, that the state devised for when we lost all these psych beds, because they're finding that it's just fallen on the ER. So to try to help out, they've made these mobile units in each county supposedly to help evaluate the patients.
Is there a missed opportunity here of maybe not utilizing the mobile crisis teams to go to the scene? I mean, is that happening? Are EMS or police, when they're encountering a patient who they think needs psychiatric assessment but isn't in imminent risk, I mean, just so I understand, are they allowed to be called?
Yeah.
Yeah, I mean,
They go to
in
scene calls in
Rockland-
Dutchess.
Do we know,
And the-
do we know their
We don't know their numbers. We could get them.
You know, the problem, like,
Because I've
said
definitely seen patients, you know, in the Hudson ER who were brought in, not by their parents or anyone else, that were brought in by an ambulance or by police, who did not have any, like, who were not completely intoxicated or anything, that really just needed to get plugged in, like the appropriate mental, and all I do is call them, and say, what a waste of resources
Right.
that just created.
The trouble with
They
mobile,
don't need that.
the trouble with mobile mental health is they're also resource stressed, and so sometimes you'll call them and they'll be like, you know, I can't get anyone there for 2 hours. And so in those situations, pre-hospital, you know, then what's EMS gonna do? Are they gonna wait around for 2 hours?
Yeah, the police are just gonna bring them.
You know.
But families know, families know to call and to ask for help. But again, it's not a perfect system, but it is out there. I just wanted to make sure, I didn't really realize that was the resource that they have put up as a idea when all these beds were gone.
We'll take the beds.
Just a point of clarification, so EMS or first responder, whatever gets involved with the mobile health care team, that's an okay for them to leave that patient behind and not transport him. Is that clear?
It may or may not be.
Yeah.
Well,
I mean, that's a
that,
decision
that,
they need
that
to
needs to be
Something the
very
courts will
clearly
fight
pinned
out
down.
over.
Yeah, I
If
think,
this thing is gonna work, otherwise it's a total waste. If they're gonna transport no matter what, why have the team come to the,
well, it might be a place where the EMS has not been called. The mobile mental health just came to the house because they have a relationship, they know this patient. A lot of times they know the people in the community. They know who's around and who's where and who acts up and what happens. And they actually, like Mark said, sometimes come in and give a little TLC and the situation is cooled down. And they orchestrate, you know, hey, see your guy tomorrow, blah, 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 blah. But they will decide if somebody's in imminent danger and they don't feel that it's safe for them to stay there, then they'll call a EMS agency, or if they need to, police, if it's a real aggressive person, to bring them in. Because they don't transport. They don't transport. They're, you know, they just, you know, evaluate.
I think we'll see what there are. I see what you're saying, though. There are certainly some potential issues that could arise when they're called, and then mobile intervenes, defuses the situation. But then, I mean, is the patient signing out AMA or is the RMA? Or
The medic would have to decide, or
Yeah.
first responder, what the scene's like, what they feel comfortable with, and they make it just like anybody else. And they should transport if they're there.
Okay, but do they, you know, given the assessment of this mobile, you know, the mobile crisis team, can they say, you know, discuss with the mobile crisis team, the mobile crisis team feels that the patient does not need to be transported to the ER, is that enough for EMS to document and walk
I
away
would
from
call
that
medical
protect-
control.
Safely?
I would call medical control and have a discussion.
Okay.
Or a pre-existing policy by the agency medical director about what the plan is gonna be for that. You know, I don't really need to call every single time if you know, as long as you have a policy around it.
Just so that people have resources. I want them to be able to, you know.
So just for context, we've been doing this for, I think, almost 3 years at St. Luke's, and about 60% of the time, we divert them into community stuff.
Okay, thank you, everybody.
Yeah, I'm sorry.
Ooh.
We may just need to make a clear recommendation on this from this group to EMS agencies to be able to follow either a policy by the medical director, call medical control, or have something that they specifically can do to give them clear guidance, because it may end up being an issue if you have police, EMS, and this group on the scene, who's doing what.
Well, I
want
think-
for some of our guys to be clear about that,
I think-
especially if there's volunteers that don't come to a lot of these things or get information from their counselors or things like that.
I think if they're called to a scene, they do the same thing they'd call no matter what it is. If it's a heart attack, a person can't breathe or whatever, they do the same thing. It shouldn't, the mobile mental health should not impair what their general practice is, because we don't want to deviate. However, if their medical director has devised a plan for them and signed off on it, and it's something they approved to and have notified and let everybody know, then that's a different story. But I think you have to just do it the same way as if you, approached any kind of patient. And if they've been called there, they should transport, the patient if they've been asked for help. If the patient doesn't want to go and they feel comfortable that the person can RMA, then that's fine. If there's a discussion, I would call medical control and ask for assistance.
No, I completely agree with you.
You know what I mean? I think,
Adding another piece into it.
yeah, I just think,
I don't wanna know what to do.
I think we need to keep it the same way for everything across the board, just so there's not these exceptions that everybody needs to learn about. It's just the way it is. This is the way you respond to a call, no matter what the complainant was.
I think if mobile crisis is evaluating a patient, at the very least, if they're comfortable saying the patient can stay home, then they're saying that the patient has capacity.
And the patient should be able to sign,
In which case you can call,
Make a decision.
medical control and get an RMA.
yeah, and they should just have them sign.
So then that's the plan. Needs to be a plan.
Mr. Murphy.
I can't see you, Mike, sorry.
I normally don't disagree with my distinguished colleague, but I think that most of the behavioral health response teams, mobile mental teams are run on a local basis, and I just think it should be left to the locality. We have a perfect system in place in Rockland with our volunteers and with our agencies and with the behavioral health social worker who happens to be the clinician of expert on the scene, and that's been realized and accepted by everybody. There's a plan by medical directors. I would respectfully ask the Remac just to kind of stay out of it right now and just let the individual teams do what the individuals do, not do a broad.
I think that's what we're doing.
Yeah.
So, but just a clarification, so if the medics do get called, so that's okay for them, is that right? Is that sort of?
Sometimes the medics on scene will call, they'll realize this is not a medical emergency, this is
Okay.
an emotional issue, this is a behavioral issue, this person does not really need to go to the emergency room, it's not in their best interest, and they'll call the behavioral health response team, who will come over, they'll transfer care to the behavioral health response team because it's a behavioral issue, and then they'll go back in service, and then the behavioral people will deal with the person, and a lot of times do what they need in PLC, maybe a half-hour engagement, referral to, MHA in Rockland, and everybody goes about their business, and the patient gets what's really required. Obviously, if the medics get there,
Maybe
they're psychotic or whatever, they're not even gonna call behavioral health. So that's the way it works right now. It works well.
And there hasn't been any, no one is trying to come back on EMS for this. Okay.
So that's more of an agency policy organization. So I think that fits in appropriately.
Yeah, I don't think anybody's saying
In the
the,
absence of that, what do you do in that situation?
Yeah.
Obviously, you have, clearly, you're highly evolved in this regards, and we're talking about a situation where someone might not have this policy. I don't think we're trying to.
No, I understand that, I understand.
And I think that agencies who work closely with these and have this system set up, right, but that's already worked out through a medical director and agency policy. But I think what you're saying is you don't have a working relationship where you don't have any clear guidance in certain areas. There might need to be something there, but it wouldn't supersede what's already in place.
Correct.
That works in other areas.
All right, great. CMAC report. So, Mike, I don't know if you want to jump in at any time. I missed it because of family illness. However, the notes pretty much from the committee, a few things went through from different areas, some protocol changes. CMAC had sent out an advisory regarding hyperventilation in severely traumatized brain injured patients. And they removed a very, very old advisory that was out about hyperventilation, which was still out there in the book. So they made sure that came down.
Just for the record, that was 9703, which was redacted.
Yeah. And there was a presentation by the Coverdale Stroke Hospital Data Collection Program. That's the centralized New York stroke program that takes all the QI data from all the institutions. They made a presentation. There was a lot of discussion about the statewide BLS protocols and how the Training and Education Committee are going to come up with the protocols and a system for them. I don't know if you want to add anything.
The only other thing is that the state has also decided that the critical care program would be sunsetted.
Oh, yeah.
There will be no new programs approved after January 1st of 18. And lots of dates were thrown around, but I believe that no recertifications after 10 years from that. So January 1 of 2028, the CC program, all CCs would have to either bridge to a paramedic, which was discussed, and they're going to develop a program for people to bridge up, or they can go down to EMT level. But extensive discussions, and everybody really was understanding of the need to eliminate the program because there's not a national curriculum. They estimated the cost to keep the program around would be $1.2 million because of the materials that would have to be rewritten and certified for only 1,500 providers across the state.
And so now they're going to disperse that money to all of us?
Oh, yeah.
That'll be coming in
Your check's in the mail.
your next check.
So, yeah, that was a big discussion because there were some areas in New York State that still heavily relied on CCs.
Yes.
And so what we did was, through the collaborative protocol, was say, you know, and Mike made the pitch of a transition program, a program to just do a certain amount of interaction, education, supervision, make sure they're comfortable with certain procedures, and to bridge them to the paramedic level, which only makes sense. And so hopefully this will flow forward and freely. They had a lot of discussion about the stroke protocols and primary stroke centers and comprehensive stroke centers. So that's pretty much what they wanted to make sure is the last known well time was on all these interactions, online medical control to be contacted, and they were suggested changing the 3.5 hours for transport destination decision to 6 hours. So, you know, just so that patients get to the participating stroke centers rather than to outlying institutions. Check and inject demonstration project with 635 agencies participating. 77 uses were done over the last quarter since our last meeting, and there were no reported problems. And that was about it. The CC thing was the biggest discussion.
At the training in ed, they're no longer issuing instructor notifications. If your instructor card is gonna lapse, you have to know it. It used to be they'd send you a letter a month or two ahead of time. They're not doing that anymore. Instructor exams, the folks that are taking it, the CLI seem to be doing better. About 80% are passing that. The CICs, about 70% are passing that. On-site scoring was a big discussion. You can do on-site scoring, but you cannot get a piece of paper saying if you're cleared to go to work. They found that there were some issues with course sponsors not sending in all the correct paperwork, and they were issuing cards to people that hadn't finished all the course requirements. So now you can take the on-site scoring for your own satisfaction, but you still have to wait for the card to show up before you go to work. The regional faculty update that they were pushing has died because of lack of funding. The budget constraints, Lee Burns talked about that. They can't fill any of their positions. The budget last year was 6.3 mil. This year it's 5.7 mil, but they've been given a cap of 4.9 million to run the office. The new Office of Hospital Emergency Preparedness contract is coming out, and there's going to be a regional point of contact. The region or myself is supposed to be notified about it. They want EMS involvement in it, but there's no grant money available for EMS funding or EMS involvement in this thing like we've talked about before. The next SEMSCO is the 26th, 27th. They're reviewing the statewide mobilization plan.
All right, thanks, Rich. Under announcements, we talked about Cragsmore and Putnam, the two new programs, and voted on it. From the Department of Health, there were 2 citations sent down. For the Westfield Fire Department, the Village of Westfield, New York, has been suspended for 1 year and assessed a civil penalty of $5,000 for violations of Part 800. And Andrew Lessay of East 10th Street, New York, from Manhattan, was suspended for 1 year, effective June 9th. And he has a 6-month actual suspension serving concurrently for a violation of Part 800. He was assessed a $2,000 civil penalty. And he is required to report back. They have all these stipulations for him. Those are the notifications from the state. Now open forum. Anything anyone wants to bring up?
I have 2 announcements. The first is that there is going to be an educational opportunity which is called Navigating the Business of EMS, a Strategic Vision. It's run by the Catskill Hudson Area Health Foundation Center. It's July 14th from 8 to 4:30 at Marist College. And Bill, is that up on the website? So you can get to it on the website, but I know that there's been some fairly wide distribution of that. It's an all-day seminar, so that may be a good opportunity for some folks.
Those are really good seminars that AHEC does. Done the last number of years ago.
And then the other thing that I just saw this morning also is that there is a grant which is available through the U.S. Department of Agriculture for distance learning and telemedicine. And so I know at the state there was lots of discussion about distance learning for those folks that need to take advanced programs in some of the rural parts of the state. One of the biggest complaints with them doing away with the CC program is that their providers need to drive an hour to get to a class. So if anybody is interested, U.S. Department of Agriculture, distance learning and telemedicine grant. That's all I have, thank you.
Anybody else? Yes.
Matthew Brennan with
Matt.
Life. Epinephrine 1 to 10,000, the shortage. Am I correct in remembering that several years ago we were in the same situation and there was guidance provided by the Remac as to what to do?
Yeah, I think we sent out an advisory at that time. So yeah, we'll revisit it. That little Karen sitting right next to you, she's a good resource person. Yeah, we had said.
We're at the point now as an agency where we do not have 10,000 epinephrine.
The other thing that's really, it came out in my, one of my throwaway journals electronically, that sodium bicarb is now like becoming extremely short, that there many institutions are canceling elective surgeries that would require the use of bicarb in their procedures or whatever they're doing, and they're going to cancel them because the shortage is to that much of a dire strait.
We were down to 4 lorazepam in the hospital last week.
Wow.
Lorazepam.
We have 8 lorazepam.
Yeah.
She's
at least you can get Valium and Versa, you get other options.
And sodium bicarb at our hospital, like out.
Pretty soon it's going to be chicken soup. And the hug.
I know. We do have Haldol. We do. Yeah.
Yes. Dave.
I have something different.
Sorry?
I have something else.
Yeah.
All right. Dave Grass, Mobile Life. Just to kind of comment, I heard the protocol committee talk about before adding high-risk, low-use procedures into our protocols. Once we adapted the collaborative agreement and we diversified what the protocols are across the state, I would encourage this body to look at each of these high-risk, low-use procedures that we approve and start to evaluate whether they make sense in the Hudson Valley. Just because a region that has 5 critical cares doing something in the field may not make sense here. And I don't want to just see us get into a situation where just simply because another region in the state is utilizing it, that we now put that risk on the agencies. And you start looking at the agencies, it doesn't make sense for them to be doing it. You know, and one can argue back and forth whether the OG insertion post-intubation here in the Hudson Valley has a relevance. And I'm sure the argument can be made that occasionally it will. There will be a situation where it's relevant. The question is, if we write that into a protocol and then ask our ALS providers to do it, they're going to now question, is that something that has to be done before it gets there? What if I don't use it? What are the risks of that? So I would encourage, you know, the Remac, as we look at all of these high-risk, low-use procedures that have benefit across the state, do they make sense here in the Hudson Valley before we just simply implement them?
Yeah, I
What do
can,
you think of that?
yeah, definitely, I think we keep that in the back of every conversation, and point well taken. Under the protocol, it's used to consider. It's not something they have to do, but they can consider it if they feel that, you know, they think that it would assist the patient. Are they having trouble bagging? Are they, you know, certain things happening, and is it a distance for them to get to where they are going? You know, so it's there as consider.
And I respectfully agree with that. Unfortunately, some people will interpret it, it's now in the protocol, does it have to be done? And how are the receiving facilities going to say, why wasn't this done prior to arrival? Again, for anybody that's been in the back of that ambulance when all heck's breaking loose, is that a priority of something that they should be thinking about, and how will it be received? All I'm asking for is consideration as we move forward, adopting some of these high-risk, low-use skills.
Yeah, that's why it says consider.
I don't worry too, I don't think,
Yeah.
I mean, I don't think the majority of receiving facilities would be upset about the lack of an OG tube.
Unless the OG tube is your ET tube.
Yeah, I was gonna say. Unless it's sucking the air out of the ET tube sitting in the esophagus in a circuit.
Point well taken. Okay, any other comments, concerns, or anything in the open forum? All right, I'll ask for a motion for adjournment. You guys want to sit here? Okay, thank you, and a second.
Second.
Great. Thank you, everybody, for coming. I know your schedules are tough, and I